Hello, my name is Hayden, and this is my project proposal presentation for home dialysis. Throughout this presentation, we are going to look at the background of the project, the needs assessment, stakeholders, goals, requirements and tools, and then a literature review. So, dialysis is a small sector of healthcare. However, it's also one of the most financially demanding on our taxpayers through the Medicare program and our government. Patients who are diagnosed with acute kidney injury or chronic kidney disease are usually set up with a catheter and placed on dialysis till they either regain kidney function, receive a transplant, or unfortunately pass away. Traditional in-center dialysis, or ICHD, requires patients to come in usually 3 times a week and receive a 4-hour treatment. This is usually dependent on the doctor's orders, but this can also be very harsh on the body and insufficient for a patient's lifestyle. Home programs such as home hemodialysis and peritoneal dialysis, or PD, are other options that patients have, which is accomplished at home during the night or multiple times every single day for shorter periods of time. While these options are not new, Trin and Chan explained that the implementation of Medicare end-stage renal disease, or the ESRD program, in 1973 led to universal coverage of dialysis and transplants. This funding led to a surge of for-profit dialysis units where physicians and facilities were incentivized to grow in-center hemodialysis. So home hemodialysis slowly became less and less promoted. However, home hemo and PD are becoming more recognized as the preferred method of dialysis, as it leads to better health outcomes for patients and is more cost effective. Ferneck explains that the vast majority of dialysis staff perceive home modalities as better for the patients. This leads to my project at hand, increasing the use of home programs among dialysis patients. Having worked in dialysis for 4 years, I understand the impact that dialysis has on a patient's life. It would be a project that would lead to better health outcomes for the patients. It would also help manage patient acuity levels by allowing patients who are stable and independent to be able to dialyze on their own time, and this would alleviate some of the burden on the staff and allow them to focus on patients who need the in-center supervision. The setting for this project would take place in individual facilities, and they would focus on driving outcomes for the patients and continue to be the first line of defense in educating our patients and their families. The company has also taken an interest in driving better outcomes for home modalities. However, it is ultimately up to the patients, which is why education is so important. Ferneck explains that patients in-center were not informed that there were other options to receiving treatments other than the ones they were currently using. There would have to be many people involved and willing to promote the use of home modalities. Nurses are the main staff members who treat and train the home dialysis patients, so they would be the main points of contact. Other contacts would include the facility administrators. They look at the health outcomes and they also grow our facilities. The medical directors, who ultimately accept or deny patients into the different programs. And then also the regional operations director, who manages the overall operations of our facilities. Recently, there has been a massive increase in the political pressure to change our healthcare system. Malhotra explains that dialysis has been receiving much of the attention since 2008 and the passing of the ACA. Since then, dialysis has had few changes to the provision and payment of dialysis. In 2019, there was an executive order that was passed and states, it is the policy of the United States to increase patient choice through affordable alternative treatments for ESRD by encouraging higher value care, educating patients on treatment alternatives, and encouraging the development of artificial kidneys. Despite anyone's political beliefs or views, this serves as a benefit to the dialysis field and shows that change needs to take place to improve the lives of our patients. There continues to be growing research and evidence of the benefits of home programs. Many of these studies show different cost savings, better clinical outcomes, and a more patient-centered experience. On another note, Byron explains that the use of home dialysis modalities in the United States is far less than that of other countries. He states it is possible to greatly expand PD and its use successfully in a large integrated healthcare system and improve outcomes for patients with chronic kidney disease. Moving on to stakeholders, when someone receives dialysis, there are many people involved in the process. The three major stakeholders are the patients, providers, and the payers. It's the individual responsibility of the patient who drives the outcomes that are seen. Whether they want to support, create a negative impact, or remain indifferent on their choice to go to a home program solely relies on them. However, there is a lot of responsibility on the staff and healthcare providers to promote and educate these patients on the use of home modalities and the impact it could have on their lives. Glickman and Seshase explain the benefits of training programs and how it provides, quote, clinical exposure and enhances the opportunity to translate knowledge into practice. Patients may be hesitant to immediately transfer to a different modality because of their fear of doing dialysis on their own or just the lack of education to do so. Most patients do have the ability to do home dialysis, and this could be addressed by encouraging them to either talk with current home patients or just be offered plenty of time and resources to practice setting up their machines or do self-cannulations. Providers also need to be well educated in the home programs and how to monitor and assess patients who are utilizing these modalities, because otherwise they will not promote them. Medical directors should be fully educated and prepared to make decisions on who is able to be put on home dialysis and who is not. Providers also include trained nurses and technicians and being able to train patients on how to treat at home. Patients will come in for monthly or weekly checkups where the nurse may draw labs and monitor their progress while dialyzing. The payers mainly include the governing agencies and the government through the Medicare program. This also includes taxpayers as well. We all have the innate responsibility of making sure that our money is well spent and used for a good cause by ensuring that different modalities are not being wasted or underutilized. The taxpayer's dollar will stretch much farther within the dialysis field. Insurance companies may resist different modalities because it strays away from the traditional 3-day per week model, which made it easy for reimbursement. However, and this could require improvement on the reimbursement policies for home modalities. That being said, it is important to remember that even though there are different parties with different goals and objectives that may serve their own interests, we have one main objective, which is to better the lives for our patients. Just as Christ said to go and preach to all of creation, we should have the same approach with the impact of our care. The focus is the patient's life and well-being, and we should try to improve the lives of everyone we encounter and help them throughout their lives. The goals of this project remain straightforward. We want to increase the percent of patients that are using home modalities And my current company and other organizations like it are saying goals like 25% by the year 2025. The chart on the right displays the United States standings with the percent of patients receiving in-center care, home hemo, and other modalities compared to other countries. And you can see we are high on the list there. Other goals consist of achieving better health outcomes for patients, controlling the rising healthcare costs in dialysis, and better manage patient acuity across all modalities in our facilities. The main resources that will be needed are more staff, both in training and sold on the promotion of home modalities. Without the medical director's agreement on using home modalities within specific facilities, then the programs won't exist. This is also why there may be a need for more government incentives or more robust than that are more robust than the current executive order. There will also be a need for more home equipment, including machines and home resources and training and education for patients, their families, and providers. The tools that will be used are mainly from reports. The baseline costs for in-center treatments versus home treatments will have to be analyzed and compared to highlight the success or failure of the program. There will also be patient health outcomes such as adequacy, calcium levels, blood pressures, mortality, and hospitalization rates. The graph on the right is a great representation of the different negative outcomes that are assessed from patients. For in-center patients, missing one treatment out of the 3 can lead to massive detriments on a patient's health. For home modalities, many of the factors shown in the graph could be avoided and lead to better health outcomes. For literature, there is an abundance of literature available that discuss dialysis and the different modalities associated with it. Other than the articles that I've gone throughout this presentation, there are many different other articles and studies that directly address the benefits of home modalities as compared to in-center treatment. Many studies compare the data found within different countries, which would be beneficial to this program. There is also data on the different health benefits and cost benefits between different modalities. And there is also data that can be retrieved from specific facilities and how these different treatments impact facilities in different areas. There are also interviews and testimonials that could be used and would benefit the overall outcome of the project. The most important thing to remember is that the patient is the center of our care. The reason for this project is to ultimately better the lives for more dialysis patients and provide more opportunities for dialysis organizations to impact our patients and providers. This project embodies the message of preventative and self-care. Patients who move to home programs are more likely to take health more seriously and have a bigger sense of responsibility for their own outcomes. It also empowers the patients. They can continue working and living their lives as normal as possible without the need to go into a center 3 times a week at a scheduled time. It ultimately gives the patients a better quality of life and satisfaction of care. It is easier on the body than in-center treatment, and it is more effective at removing waste and replacing electrolytes. From a biblical perspective, these outcomes are also important. We know that the Bible tells us that our body is a temple for the Holy Spirit, and we should take pride and responsibility in keeping ourselves as healthy as can be. Especially dialysis patients, because their bodies become very fragile, and whatever we can do to improve our health is important that we do so. We know that God wants us to be in good health because it is good for our souls. We also know that the only way to truly be satisfied in this life is through